Hi, this is going to be about Parkinson's disease and the medications we can use for it. So, first of all, let's talk about the pathophysiology of Parkinson's disease. So, if you can imagine a seesaw, if you have one person that's 200 pounds and one person that's 20 pounds on it, what's going to happen? Obviously, all the weight will switch to the person with the 200 pounds, right? So, this is kind of the similar thing in Parkinson's disease. So, dopamine is the 20-pound child, right? So, this would be inhibitory brain dopamine. And then excitatory acetylcholine is the 200-pound adult. So, what do these neurotransmitters do in the first place? Well, a balance of dopamine and acetylcholine is important in regulating posture, muscle tone, and voluntary movement. So, the symptoms of this disease are due to the excitatory acetylcholine. So acetylcholine we can think of as our muscle man, okay? So usually the first observable symptom is a resting tremor with pill rolling movements. So if you can imagine pronating and supinating your hand involuntarily, this is what the first symptom usually is of Parkinson's disease. Another symptom is bradykinesia, which is slow movement because of the brain's slow transmission. Make sure you understand that is slow movement. Akinesia is no movement, but bradykinesia is slow movement. You can remember it like bradycardia is low heart rate, so bradykinesia is low movement, okay? So it also manifests with rigidity in the limbs, postural instability, because as we said, one of the things that a balance of dopamine and acetylcholine does is to help you be stable. So you kind of walk a little bit like an orangutan, and you have a mask-like expression, so people mistake it for apathy a lot. And you have a soft speaking voice. I said that you have a soft speaking voice. And drugs that block dopamine receptors can also cause Parkinson's disease symptoms. So as we talked about, haloperidol and phenothiazines can produce secondary Parkinsonism. And so low dopamine is what we usually think low dopamine when we hear Parkinson's. So the drugs that block the dopamine receptors, as I just said, can also produce tardive dyskinesia, which we already talked about. It's an extrapyramidal disorder, which may manifest with lip smacking and tongue profusion and facial grimaces. So all of that is involuntary. And then dystonia is uncoordinated, bizarre movements of the neck, face, eyes, tongue, trunk, or extremities, which can happen also with when they block the dopamine receptors. And then akathisia is the loss of movement. So if we remember that there's not enough dopamine, the kind of drugs we would need would be what? Right, so we would need drugs to increase the level of dopamine. So dopaminergic drugs are very common in Parkinson's. So why would we use them? In idiopathic Parkinson's, medication Parkinson's, and conditions that are like Parkinson's, we would use them. So the prototype of dopaminergic drugs is levodopa carbidopa, and it's a combination drug. So let's first talk about levodopa. So it circulates in the plasma to the blood-brain barrier, okay, where it crosses, and it's funny because levodopa, if you see DOPA, that starts with dopamine, and levodopa is the prereq to dopamine. So once it crosses the blood-brain barrier, it's dopamine. So this is affecting it in a very, very direct way. And then carbidopa is affecting it more in a indirect way by inhibiting the peripheral plasma breakdown of levodopa. So it inhibits the decarboxylation, and that increases the amount in the blood-brain barrier of dopamine. So meaning that, like, we don't want to inhibit the breakdown in the rest of the body because we don't need it in the rest of the body. We need it in the blood-brain barrier. Okay, so what we could teach our patients is not to take it with a high-protein meal because this increases the effects of the medication, but do give it with food to decrease the nausea and vomiting. And it takes several weeks to start working. So we have to encourage people to be patient, even though it's really, really hard. And just remember that this is reserved for significant symptoms. And also we can't take an MAIO with it unless you want hypertensive crisis, and you don't. And so let's talk about the adverse effects, but let's understand them and not memorize them. Because if we're going to memorize them, we're not going to know them. But if we understand them, we might know them more. So CNS side effects, okay? Obviously there's going to be CNS side effects because it is working on the CNS, right? So headache, anxiety, right? Hallucinations, remember, because they're increasing the amount of dopamine. Dementia, drowsiness, depression, and then a big one that can be fatal is suicidal tendencies. So you have to watch the patient for this. And then in cardio, it causes vasoconstriction, which is like, the constriction of the certain of the vessels, and it causes tachycardia, palpitations, angina pain, orthostatic hypotension. And as we know, orthostatic hypotension is the change in blood pressure as we sit up and lie down and sit up and lie down. And so you would need to tell your patient to get up and down slowly so that they don't have a huge effect of orthostatic hypotension. And like all other drugs, nausea and vomiting are two symptoms, and you can't really ever get away from those no matter what drug you're taking. Okay, so contraindications are narrow angle glaucoma, which is basically in the eyes. There's a problem with the vascular system of the eyes. And depression, hypertensive crisis, because remember, it raises your blood pressure. So if you have hypertensive crisis, then there is no reason that you need it to work on raising your blood pressure. Peptic ulcer disease, and then any kind of severe disorder could be cardiovascular, pulmonary, renal, hepatic, or endocrine. But any kind of like serious disorder, we need to take a step back and say, hey, wait, like, is this the right drug for us? Okay, so the other medication type we use for Parkinson's is the Compt Inhibitors, and that inhibits the enzyme that plays a role in brain metabolism of dopamine, and metabolizes about 10% of peripheral levodopa. So we're inhibiting the metabolism in the bloodstream, and that increases the drug's action time, and it may prolong activity at the synapse. As we talked about in my last video, the more time it's at the synapse, the longer it works. And just remember, though, this medication is only used with levodopa and carbidopa, so it's a combination. This is called tolcapone, the medicine I'm talking about now. There's also one called entacapone, which we'll talk about it in a minute, and that's a safer one, so that's used more often. And then black box warning is that patients risk potentially fatal acute sudden liver failure. So a nursing implication would be to monitor liver function tests before therapy begins and then every 2 weeks after, so that we lessen the risk, or at least we know when it's happening. And then side effects, we have CNS side effects, okay? You'll think about it and you'll get it. And then there's dizziness and orthostatic hypotension. And then for patient teaching, make sure to tell them they need to use barrier contraceptives, because they need to use barrier contraceptives, and don't breastfeed when they're taking this medicine. Okay, so there is a 3-drug combo product called Stavlo. All yours for 1,000 payments of $19.99. Just kidding, but it's a catechol-methyltransferase inhibitor and deoxycarbolase inhibitor and dopamine precursor. So it's all of these in one, and it's very, very heavy duty, and you can use that when you need a lot of extra support. So again, that's called Stavlo, and it is combined with levodopa, carbidopa, and entacapone. So that's it for Parkinson's. The next one I'm going to do is anticholinergics, which is very similar to Parkinson's because a lot of these drugs are used for Parkinson's, but I thought it would be better if I did it in another video.